Welcome to This Explainer, everyone. Today we are unpacking one of the most incredible, high-stakes transitions a human being will literally ever go through. We're talking about the journey a baby takes from dependent in utero life to an independent ex utero existence. The protocols we're looking at today, they are absolute lifesavers, mapping out the exact step-by-step clinical playbook required to guide a newborn safely into the world.
So what really happens in those first 60 minutes after a baby is born? Okay, let's dive into this because this time frame, which you've probably heard called the first golden hour, is incredibly time-sensitive. It's absolutely critical to a baby's survival. The decisions made in these first few minutes literally set the foundation for the baby's body temperature, their breathing, and their immune system.
Here's our roadmap. We'll be covering the first golden hour, examining the newborn, postnatal ward care, normal newborn variations, and finally, danger signs and discharge. Let's get right to it.
Section 1. The first golden hour, and the crucial practice of delaying interventions.
You know what's fascinating about this first hour? It's that what we actively choose not to do is just as important as what we actually do. Between minute 1 and minute 3, the umbilical cord is clamped. Then, immediately, stable babies born at 34 weeks and above are placed prone on the mother's chest for at least 1 hour to initiate breastfeeding. We intentionally delay pretty much everything else. No weighing, no injections, just uninterrupted skin-to-skin contact. Why? Well, it prevents hyperthermia and immediately establishes that crucial bond. Now, a quick note on the umbilical cord. It should be clamped about 3 to 5 centimeters from the umbilicus using a sterile thread. But notice the strict clinical mandate here. The cord must be kept clean, dry, and free of any applications. This firmly busts a really common myth. You absolutely do not need antiseptics. Just keep it clean and keep it dry.
Moving on to Section 2, examining the newborn and those all-important crucial checks.
All right, once that golden hour is officially in the books, the medical interventions can begin. First up is the vitamin K1 injection, which is super important to prevent internal bleeding. Notice the strict weight-based distinction for this intramuscular shot, which goes right into the thigh. Babies under 1,000 grams get 0.5 milligrams, while babies over 1,000 grams get a full 1.0 milligram dose. Next up is a massive, and I mean massive, clinical warning. Do not perform a stomach wash in newborns at birth. Historically, tubes were passed into the stomach, the nostrils or rectum, just to check for internal blockages, which are known as atresia. Doing this routinely, it's an outdated, highly invasive practice that this protocol urgently and completely bans.
And this brilliantly illustrates what we do instead of those invasive tubes. The baby undergoes a really rigorous visual head-to-toe examination. The clinician is essentially hunting for any life-threatening anomalies. They're checking the head and face for abnormal features, or something like a cleft lip, scanning the eyes for cataracts, checking the spine for neural tube defects, and looking over the lower limbs for positional issues like clubfoot.
Now, during that examination, if any red flags do pop up, the baby might need to be redirected. Babies automatically flagged as at risk include those weighing less than 1,800 grams, those born before 34 weeks gestation, or babies with major congenital malformations. Also, if they're required significant resuscitation due to asphyxia, meaning a lack of oxygen, or if they're having any breathing difficulty, they completely bypass the regular ward and go directly to the special newborn care unit.
All right, Section 3, postnatal ward care, which is basically our observation phase. For the vast majority of healthy newborns, they room in with their mothers for observation. And during this phase, one of the things that absolutely terrifies new parents the most is weight loss. But let's look at expectation versus reality here. It is perfectly normal for a term baby to lose up to 10% of their birth weight over the first 2 to 3 days. The actual red flag, that would be any weight loss greater than 5% in a single 24-hour period. That rapid drop means something is definitely off.
So how do we actually know if feeding is adequate without just obsessively staring at the scale? Well, the magic number is 6. An adequately fed baby should pass urine at least 6 to 8 times a day after their first 48 hours of life. If they're hitting this number, it's an excellent, really reassuring indicator that breastfeeding is well established.
Moving on to Section 4, normal newborn variations, and a little bit of myth-busting. Let's be honest, newborns do some strange things that cause immense anxiety, so we really need to separate the normal variations from the actual red flags. Transitional greenish-yellow stools? Completely normal. Crying from a full bladder or soiling? Normal. Spitting up small amounts of milk?
normal. But the real red flags that require immediate action, those would be failing to pass any meconium, their first tar-like stool, in the first 24 hours, or experiencing persistent projectile bile-stained vomiting. Those are serious.
And while we're on the topic of what parents should and shouldn't worry about, we have to talk about traditional practices. Some traditions are fine, but several harmful practices must be actively discouraged. Applying kajal or surma in the baby's eyes? No way. That can cause infections, severe injury, and even lead poisoning. Putting oil or boric acid in the nostrils is highly dangerous. And applying cow dung to the umbilical cord is just a massive infection risk. These specific actions literally have to be firmly counseled against.
Bringing us to our final chapter, Section 5, Danger Signs and Discharge, our final checklist.
As we approach that 48-hour mark, the clinical team runs through a vital final checklist. A massive priority before the baby can even think about leaving is immunization. Within the first 24 hours, they absolutely must receive 3 crucial vaccines: the BCG vaccine, the 0 dose of the oral polio vaccine, and the hepatitis B vaccine.
But honestly, the most important thing a provider can do is educate the mother. If the baby develops jaundice within 24 hours, fails to pass meconium in 24 hours, or urine in 48 hours, shows any respiratory difficulty or cyanosis, bleeding, persistent vomiting, diarrhea, seizures, or sudden temperature changes, the mother has to know to return immediately. Making sure parents understand these signs is the ultimate life-saving takeaway.
So let's summarize the discharge checklist. These 4 ideal conditions must be met at the 48-hour mark. 1. The baby is totally free from illness. 2. The baby is fully immunized with their initial doses. 3. Breastfeeder is clearly established. And 4. The mother feels confident and is fully 100% aware of those danger signs we just covered.
And remember, leaving the hospital isn't the end of the clinical protocol. The final steps before waving goodbye are scheduling a well baby follow-up visit and advising the parents to administer 400 international units of vitamin D per day to the newborn.
As we wrap up this explainer, I want to leave you with a final, provocative thought. We've seen how intensely managed and regulated the clinical environment is from the very second of birth. But here's the thing. We can perfectly manage the golden hour in the clinic, sure, but are we doing enough to truly empower mothers to recognize the danger signs once they get home? Because when it comes down to it, clinical success ultimately relies on a confident, educated parent. Thanks so much for joining me to explore the newborn journey. Keep learning, and I'll catch you in the next explainer.